Bismillahirrahmanirrahim. Dear students, this is the screencast for suprarenal gland adrenal gland pathology. This is the screencast for suprarenal gland pathology. So as usual, we expect something you guys to do after this lecture in simple terms, simple explanation. So that's what we want you guys to do seriously, certain things that is called intended learning outcomes. So that determines our how about the effectiveness of the lecture. So by the end of this lecture, I expect you all to do can able to do the list the causes of adrenocortical hyperfunction and its effect in metabolism, blood pressure, gonadogenesis, immune system, and serum electrolytes, which means you should be able to list the causes where the adrenocortical goes for some hyperfunctioning and releasing more adrenocortical hormones, and its effect. You can able to list the effect on various its functions. Meanwhile, we also expect you guys to tell explain the causes, pathogenesis, clinical features of Cushing syndrome and its long-term effect on various systems, and explain the pathogenesis and clinical features of acute and chronic adrenocortical insufficiency like adrenal crisis and addition disease, and differentiate the morphological outcome of adrenocortical adenoma and carcinoma because it is a tricky one. You should be able to differentiate morphological ground and what is the net outcome of it. And you guys describe the morphology and clinical outcome of Pheochromocytoma and neuroblastoma. Yeah, it's very, very important and very relevant one. Inshallah, when you go to the clinics, you will know the importance of these applications. So with this introduction, let us go into the suprarenal gland. As usual, our style is starting with basics. What you guys seeing is, yeah, it's a normal suprarenal gland and it has cortex. The yellow color border, it is cortex, and the vascular area in the center, okay, it is little bit dark red in color. If you can able to see closely, it is medulla. Okay, so these are the cortex in histology and this is the medulla. So what I was saying, why the cortex is yellow in color, because these cortical hormones, they use cholesterol for its synthesis. So they have a lot of lipid in the cortex, so that's why it looks yellow. It's like full of fat, and the cortex consists of 3 layers. And it's easy to remember as a GFR: glomerulosa, fasciculata, reticularis, and glomerulosa synthesize and secrete. The cells in the glomerulosa synthesize and secrete mineralocorticoids, and these are the cells of the glomerulosa and cells of the fasciculata and cells of the reticularis, GFR. And what you guys should know is glomerulosa cells secrete mineralocorticoids after it is gets stimulated by the ACTH. And remember the mineralocorticoids, how to remember G, and mineralocorticoids help us to carry out the maintain the vitals, okay, directly and indirectly. So you can keep like it drives us. So GM is the motor company, so it's like driving. So you can, if you remember this GM, okay, you can easily remember rest of the things which I'm going to say. So zona glomerulosa is the one which drives like a GM cars. That is GM, glomerulosa mineralocorticoids. Now fasciculata reticularis, and fasciculata secretes cortisol, are called as glucocorticoids, and reticularis secrete testosterone, androgen sex steroids. Okay, so if you remember one, you can automatically remember the other things, and other way they say yes, it's a MCA, like that. I felt like this is the best way to remember these things. And GFR, glomerulosa fasciculata reticularis, and glomerulosa secretes something which drives, which keeps us maintain the vitals, and it's like a GM and cars, and remember just like that. And glomerulosa mineralocorticoids, fasciculata cortisols, reticularis androgens sex steroids. And the medulla, it is made up of chromophene cells, and they secrete catecholamines. Some call it adrenaline, noradrenaline, epinephrine, norepinephrine. Remember, they are really important because their stimulation really important, especially in the vascular system. So I don't want to go into the vascular physiopath, so just keep this in your mind. And now coming to the biosynthesis of adrenal steroid hormones. Well, like brothers, I also don't like biochemistry, so don't worry. So I will not teach too much of biochemistry. I study biochemistry on perspective, which is essential for us to relate the clinical features and how to come to the diagnosis. So I study biochemistry totally in application perspective. So I hope that is enough. Like certain areas we should know in detail, but for this, if you guys can able to understand, that is enough. That's what I am feeling. I hope Dr. Nagua don't hear this. So now coming to the cholesterol, and it is the backbone of all these hormones. Okay, they use P450 chain of events, okay, to break down this cholesterol and to form these hormones, right? So if there is deficiency of these chains, okay, they are basically hydroxylase enzymes, so automatically this will not be produced, that is aldosterone mineralocorticoid, then cortisol glucocorticoid will not be produced. Then all this will go into the direction of production of more androgen. So just keep this in your mind. Now biosynthesis of catecholamines. So this is from the adrenal medulla. They took tyrosine and they break them, change them, and then they form dopamine as an intermediate product, and in the end they form epinephrine and norepinephrine. See, once the epinephrine and norepinephrine finish their function, they cannot be excreted out in the kidney. So what they do is they get converted into by these enzymes, like catechol O-methyl transferase. Even my PowerPoint doesn't like to read even the biochemical enzymes. So monoamine oxidase and aldehyde dehydrogenase. So these enzymes, they break them and they form this vinyl mandelic acid. This you should not forget. Okay, this is the breakdown product of epinephrine, norepinephrine. Okay, why? Because it is measured in the urine. We measure urine VMA level. Okay, if urine VMA level is increased, which means the epinephrine or epinephrine is increased, then you should know why the epinephrine or epinephrine is increased. Understand? So it is a evidence, because if epinephrine, norepinephrine is increased, they go to the blood vessel. Okay, they go to the blood vessel. The function is they narrow the blood vessel. They narrow the blood vessel. So they increase the total peripheral resistance. So they increase the blood pressure. Understand? So they cause increased blood pressure. The patient comes with increased hypertension. Okay, it is increased hypertension. So when they come with increased hypertension, and immediately one of the reason, if they are very young age, okay, we suspect secondary hypertension, so we check their urine VMA level. So if the urine VMA level is increased, it is due to the problem of increased epinephrine or epinephrine. Then we have to look why there is epinephrine and norepinephrine are increased. Okay, then that will give you answer. Then it is really helpful. This urine VMA, that is phenyl mandelic acid, is really useful one. Now let's go to the adrenocortical hyperfunction. Okay, so there are three basic types of corticosteroids elaborated by adrenal gland. One is glucocorticoids, mineralocorticoids, and sex steroids. Okay. So if there is excessive cortisol, it is called Cushing syndrome. If there is excessive aldosterone, it is called hyperaldosteronism. If there is excessive androgen, that will end up with virilizing syndrome, androgenital syndrome. So now let us discuss the Cushing syndrome in a simple and elaborative manner, descriptive manner, okay, rather than saying elaborative, in a simple and descriptive way. So what you guys we are going to discuss is pituitary Cushing syndrome. Here the problem is in the pituitary. The pituitary gland secretes, having some tumor, and it is secreting ACTH, and that will stimulate the adrenal cortex to secrete cortisol. Understand? So here there is increased ACTH, increased cortisol. So this is the case of pituitary Cushing syndrome. Now coming to the adrenal Cushing syndrome, here the pituitary is normal and there is a tumor in the adrenal gland that is increasing the cortisol. So that will produce negative feedback. What is the feedback? Negative feedback. It is negative feedback on the pituitary. So they reduce the ACTH. So in this condition there is increased cortisol, there is reduced ACTH. Please understand this. So this is called adrenal Cushing syndrome. Now it could be of even a hyperplasia. Okay, nodular hyperplasia happens in the pituitary gland. That can also, nodular hyperplasia happens in the adrenal cortical area of the adrenal gland, and you can see there is increased cortisol. Again this goes as a negative feedback and they go to the pituitary gland. This negative feedback mechanism, they will leads to decrease ACTH. Understand? So this is the scenario in the adrenal Cushing syndrome. Now you all should know the lung tumors are very notorious. They can secrete any kind of hormone. If they secrete ACTH, then they will stimulate the cortisol here, that will produce Cushing syndrome. And there is increased cortisol. Here there is increased ACTH due to the lung cancer. So it is called paraneoplastic Cushing syndrome. Okay, now this is a very important one. It is called iatrogenic Cushing syndrome. Here the person may be due to some autoimmune disease or some renal transplant, or due to any reason he is having long-term steroid therapy. Even sometimes in cancer we give long-term steroid therapy. So if there is a person is having some cyclical steroid therapy given in the cancer also, but now consider the person is on long-term steroid therapy. What happens is when the steroid level is more, that automatically in the blood that suppress the anterior pituitary, the ACTH is suppressed, okay, decreased. So that cannot come and stimulate the adrenal cortex. So adrenal cortex has less stimulation of ACTH, so adrenal gland goes for adrenal atrophy. So in this patient there will be decreased ACTH, there will be decreased cortisol, but the person will produce Cushing syndrome because of intake of steroid. Understand? So it is called iatrogenic Cushing syndrome. Okay, what is Cushing syndrome? Syndrome means contains lot of system involvement. So this is a female. Okay, what she is having a male distribution of hair, and her face become moon like face, and there are a lot of fat distribution around her shoulder. In the back you can see the buffalo hump, and these are the most important features, and they produce cardiac hypertrophy because of hypertension, and they have characteristic stria. These are the things you can see, and their muscle becomes weakness, female becomes amenorrhea, and they have vessels become very weak, so they produce purpura, small bleeding spots. So these are the things, and they have central obesity. These are the problems they have, and this also leads to osteoporosis, and these are the characteristic feature of Cushing syndrome. Understand? Now let's discuss about hyperaldosteronism. So anything which increases the aldosterone, okay, whether it is too much of ACTH stimulation, or whether it is adenoma, or whether we don't know the reason, idiopathic, if the aldosterone is increased, what the function of aldosterone? They from the renal tubule, this is the renal tubule, this is the blood vessel, they take sodium from the renal tubule, they reabsorb sodium from the renal tubule, and followed by water, and they excrete potassium. So this is blood vessel, understand? So the renal tubule, they take the sodium and water, and they send the potassium. In the end they increase the blood volume, automatically that will increase the blood pressure, so that's end up with hypertension. So this is the serious issue when related to the hyperaldosteronism. Now coming to the adrenogenital virilizing syndrome, let's go back. Here yani let me remove all this marker ones. Okay, so I said they use cholesterol, they use hydroxylase enzymes to break down, and they produce these hormones. Okay, now the hydroxylase enzyme is deficient, so this cannot be done, so automatically all will go and get produced to sex steroid. Now the sex steroid level is increasing, and aldosterone is decreased, cortisol is decreased. So you all know the cortisol maintains the glucose level. Okay, so they have hypoglycemia. Okay, and this guy's aldosterone is reduced, so they cannot take the sodium, and sodium is lost, right? Because aldosterone function is for example, this is the renal tubule and this is the blood vessel, so they take the sodium, right? They take the sodium along with water, they excrete potassium. Now there is no aldosterone. Understand? This is the normal function of aldosterone. If there is less aldosterone, the sodium is lost, so serum sodium is reduced, urine sodium is increased, and serum potassium is increased, urine potassium is decreased. So this will be the scenario in this case. So the salt is going out, the sodium is going out, it is called sodium salt wasting syndrome. Here there is androgen is increased, so that leads to virilizing, masculinization if it is in the female, and if it is in the male they go for precoccus puberty. So let us explain here once again. So adrenogenital virilizing syndrome, see here the cholesterol, there is enzyme block, here there is no enzyme, So these levels are getting reduced, and automatically this all goes for the conversion into sex steroids. This is increased. So the enzyme deficiency is 21 hydroxylase. So what you see here is masculinization in the females, precoccus puberty in the males, and they produce salt wasting syndrome, and salt is going, water is going, the blood volume is reduced, then there will be hypotension. If it is so serious, this will end up with hypoperfusion, and this will end up with hypoxia and hypotension, hypoperfusion, hypoxia. All three hypos, remember, it leads to shock. Now let us discuss about adrenocortical insufficiency. Adrenocortical insufficiency means something related to the hypofunctioning. Okay, so adrenal cortical cannot able to produce enough hormones. So it may be primarily due to the adrenocortical disease itself, or due to some other disease causing adrenocortical insufficiency. So primary acute adrenocortical insufficiency is called adrenal crisis. Primary chronic adrenocortical insufficiency is called Addison's disease. Then secondary adrenocortical insufficiency. What we mean by adrenal crisis? Sudden increase in all these hormones, because these hormones are really vital things, understand? So because maintaining the electrolytes, maintaining the glucose level, we need these hormones. And why it happens as adrenal crisis? Because of some infections like Neisseria meningitidis, septicemia, or gram negative septicemia like Pseudomonas, and even staphylococcus, gram positive staphylococcal infection can cause this. They will produce rapid decrease in the sodium level and the water level. Sodium cannot be reabsorbed, water cannot be reabsorbed, then glucose level goes down. That will produce serious hypotension, which leads to the shock. So this is a serious problem, and the infection also leads to disseminated intravascular coagulation. So there is like a hypovolemic shock along with septic shock. So it is very, very critical to save this patient. And this is called Waterhouse Friderichsen syndrome. So it is happens normal adrenal cortex. See, there is a massive bleeding here. So Waterhouse Friderichsen syndrome is something, the adrenocortical insufficiency happens due to massive bilateral both side adrenal hemorrhage, sudden bilateral adrenal hemorrhage that destroys the cells. So this leads to what this is called Waterhouse Friderichsen syndrome. Now coming to the Addison disease. So like many of the chronic diseases, chronic systemic diseases that can lead goes to the adrenal gland, slowly they destroy it, that will produce Addison disease. That is primary chronic adrenal cortical insufficiency, and 90% it is maybe due to autoimmune adrenalitis, tuberculosis, AIDS, or metastatic cancer. Okay, so you should know to differentiate primary chronic adrenocortical insufficiency, that otherwise called as Addison disease, from the secondary adrenocortical deficiency by seriously doing the clinical examination. Let me explain how. See, there is a kidney, 2 kidneys and 2 adrenal gland, and for example this guy got some granulomatous disease or some autoimmune disease affecting the adrenal gland, and adrenal gland is not producing the adrenocortical hormones. The adrenocortical hormones all are getting reduced, like slowly they are getting reduced. And what will happen to the pituitary gland? If the adrenal cortical hormones are getting reduced, this will produce positive feedback on the pituitary gland, and the pituitary gland goes for hyperplasia. Okay, and they will start producing more ACTH. They will produce more ACTH, right? Then they will try to stimulate it, but they cannot stimulate it. Again, they cannot produce more adrenocortical hormones. Then again the same process continues. Again more hyperplasia happens, and they produce more ACTH. Understand? When they produce more ACTH, which means the component which is going to make ACTH is also increased. That is, the parent component of ACTH is going to increase. That is called propiomelanocortin. So this is also increased. This propiomelanocortin is not only produce ACTH, they also produce melanocyte stimulating hormone. So indirectly melanocyte stimulating hormone also increased, that results in hyperpigmentation. Understand? So when there is severe primary adrenal problem and there is damage to the adrenal cortex, whether due to any form of disease, that decrease the ACT, adrenocortical hormone, cortisol, melanocorticoids, and that will produce positive feedback, and in the end they increase the propiomelanocortin, so they produce more ACTH and more melanocyte stimulating hormone, so they have hyperpigmentation. It is very, very important to know it. Okay, because when the person is having less sodium and increase potassium in the blood along with less glucose, and there is hyperpigmentation, then you can suspect there is a addition disease. So primary primary in the adrenal leads to increase in ACTH, indirectly increases the propiomelanocortin, which is the precursor for both hormones ACTH, MSH, melanocyte stimulating hormone, and that leads to hyperpigmentation in skin. The secondary reasons are the problem in the pituitary. So if there is problem in the pituitary and there is a adrenal gland is normal, and the pituitary cannot secrete decrease ACTH, automatically they cannot stimulate them, so there will be decrease in adrenocortical hormones. So here decrease ACTH, decrease adrenocortical hormone. So here there is no increased propiomelanocortin, so they will not produce hyperpigmentation, and even they become very pale. So what are other clinical features? They produce GI disturbances like nausea, vomiting, diarrhea, and most important thing is electrolyte imbalance, hyperkalemia, hyponatremia, and leads to hypotension and hypoglycemia. They also end up with severe shock, and cardiac problem comes because of increased hyperkalemia. So now coming to the adrenal cortical neoplasms. Adrenal cortical neoplasms, it's like other organs, we divide them into benign and malignant. Benign here adenoma, malignant is a carcinoma. So benign, if you trace, for example, this is the normal cortex, and you have see the adrenal yellow color cortex. Just you trace the yellow color cortex, and you see here it is well circumscribed nodule, right? And you can put a circle here, well circumscribed nodule, and it is full of yellow in color, which means it may be full of adrenocortical cells. They might be secreting some hormones or may not be. So if they secrete hormones, they will produce syndrome. If they secrete more cortisol, they produce Cushing syndrome. If they produce more mineralocorticoids, they produce hyperaldosteronism. Okay, now let's discuss about carcinoma. See, this is the kidney. I will change to another color like yellow. See, you see it is a kidney. See, upper pole of the kidney, the tumor is invaded here. This is the tumor. Understand? This is the tumor. It is really enclosing the kidney, and it is invading the kidney, the upper superior pole, and it is a lot of bleeding tumor, that is hemorrhagic areas in the tumor, and there are some areas of necrosis also here. So these are the morphological difference. It produces serious clinical difference between adenoma and carcinoma. Understand? Because it is invading the kidney is also destroyed. It is very aggressive tumor. One more thing I want to tell, this tumor will always have some other tumors with them, and that is leads to a syndrome called Pheochromocytoma syndrome and Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome can be associated with renal tumor called Wilms tumor. Pheochromocytoma syndrome is a p53 mutation. They may have other tumors comes due to the p53 mutation. Now coming to the Pheochromocytoma. Pheochromocytoma, it is again, it's not an adrenocortical tumor, it's an adrenal medullary tumor. Okay, so in Robbins, the old edition, if you see, they say it's a rule of 10. Because why I'm keeping it is because just to remember you guys about the rule of 10, because still some guys ask about this rule of 10. Actually, this tumor is a medullary tumor. They secrete catecholamines. See, now they secrete lot of epinephrine and norepinephrine. Epinephrine and norepinephrine. And they are bilateral. 10% are associated with hypertension, 10% are familial, 10% are extra-adrenal, which means they can see that this tumor can come apart from adrenal medulla. It can see in the paravertebral region or in the carotid sheets, that is called paraganglioma, and 10% they are biologically malignant. Microscopically they have cell ball appearance. Why I told this rule of 10 is not applicable now, because now they say it is 25% associated with familial syndrome. So clinically they produce severe hypertension because they increase the epinephrine and norepinephrine, and when the epinephrine and norepinephrine is increased, they will constrict the blood vessels. They will constrict the blood vessels, and they increase the total peripheral resistance. That will increase the blood pressure. And remember, in this case, if you do urinary VMA, urinary vinyl mandelic acid, that will be increased because there is increase in the epinephrine. So when you do a urinary VMA, urine VMA, it will be increased because there is increase in epinephrine and norepinephrine. So automatically that will lead to increase in urine VMA, urine vinyl mandelic acid. And if there is a person, young guy, having blood pressure, and that is called we suspect secondary hypertension, immediately you have to look for abdominal ultrasound and urinary VMA. Urinary VMA will be increased, abdominal ultrasound will show you a massive tumor. Okay, so this will all help in diagnosing the case, because the hypertension is due to Pheochromocytoma, and this will help. Once you remove this tumor, then they become normal. So now coming to the neuroblastoma. Neuroblastoma is the most common extracranial solid tumor seen in childhood, next to the CNS tumors, and it is commonly seen in less than 5 years. And histologically there are 3 types: neuroblastoma, ganglion neuroblastoma, ganglion neuroma. Clinically it is very important, because if the child is less than 1 year, even if they are metastasized to some other organ, especially the bone, and still they have very good prognosis. So we call them, all metastatic tumor we call stage 4, but here we use the word stage 4A if the child is less than 1 year, because they have very good prognosis. So we classified them into different stage as a stage 4A. Okay, characteristically they produce this kind of rosettes. These rosettes, like the tumor cells, are surrounding a pink color area. So it is called, it is not really a true rosette, it is called pseudo rosette, and it is characteristic feature of this tumor. It is called Homer-Wright pseudo rosette, which already we discussed in the lab session. Okay, one more thing I want to say. This is very important, clinical pathological features. And so for example, the person, young guy, having hypertension, and he usually come for headache. Okay, headache and having hypertension, and what you do, okay, immediately you suspect secondary hypertension, and immediately you ask them to check ultrasonogram to look for some tumor in the adrenal medulla, right? But there is normal adrenal medulla. You check urinary VMA, and that is increased. So it is 100% suggesting that there is increased epinephrine and norepinephrine, but there is no adrenal medullary tumor. Immediately what you have to do is, you have to do images. For example, this is vertebra. You have to search surrounding the paravertebral region whether there is any tumor, or in the person's neck, okay, whether there are any tumor in the neck. So these are the things you have to look to know whether it is a extra-adrenal. Here I mentioned it, right? It's extra-adrenal paraganglioma. Okay, so that is the clue. Okay. Okay, when the adrenal gland is normal and there is increased urine VMA and the young guy hypertension, then suspect extraadrenal ganglioma. If there is adrenal gland shows tumor and there is a increased urine VMA and it is a clear-cut case of Pheochromocytoma happening in the adrenal medulla. If adrenal gland is normal on ultrasonogram, then you have to do imaging to look for any other tumor that is called paragangliomas. Okay, keep that in mind. So this ends the screencast for adrenal gland pathology. As usual, we suggest you to read the textbook which we seriously suggest, Robbins, and in case you guys feel it is like voluminous, and then you can read Pathoma, our fellow brother Hussein Sattar's book. He has a video of that book, but mashallah, it is good, very concise, but it is a review book. Yani. Actually, for review, when you want to review something, you should have a knowledge about that subject. So only if you have a knowledge, then it can be reviewed. For the primary knowledge, you should read this book, okay? And in case any doubt, any clarification, you are always welcome to the department to discuss with us. Okay, just you mail us, we will give you a specific timing, or any kind of learning issues, to devise the learning strategies, to plan yourself and time management, or any issues you have, you are always welcome to discuss with us. And I hope this screencast benefit you all. Thank you very much.